I'm grateful for the kind invitation and happy to be among you this afternoon. I'm going to address the issue of pulmonary hypertension in patients who have left-sided failure with emphasis on reduced ejection fraction. So what I am talking about here is this, pulmonary hypertension due to left-sided disease. I'm going through definitions, prevalence, pathophysiology, clinical picture, prognosis, treatment, and the future prospects. These are the defining thresholds that we currently use. A pulmonary capillary wedge pressure of more than 15 millimeters mercury with a transpulmonic gradient of higher than 12 millimeters mercury. If we use diastolic pulmonary artery pressure, and I'll explain in a minute why it is more accurate than the mean pulmonary artery pressure, then a diastolic to wedge less than 6 millimeters is normal and above 6 millimeters is high. A pulmonary vascular resistance is normally in the range of 1 Wood unit, but the threshold for definition is 2.5. Two issues are here: the use of echocardiography versus invasive measures, as my previous esteemed speaker has delineated elegantly, and the discrepancy sometimes between capillary wedge pressure and the left ventricular and diastolic pressure. This is one example to illustrate just what he called your attention to. You can notice here that this is the end expiratory wedge and this is the digital mean wedge. We tend to rely very much on digital wedge, and digital wedge is highly unreliable in certain situations. Also, he was kind enough to show you this slide, which again demonstrates a close correlation between the end expiratory wedge pressure and the left ventricular end diastolic pressure as compared to the digital mean. Now, we have two categories here. Passive pulmonary hypertension, which characterizes the early stages of most patients with left-sided failure. It has the highest prevalence, and this situation is caused by left heart pressures. And it may remit with heart failure specific interventions, and this is not a target for therapy with pulmonary artery selective agents. This is an example of passive pulmonary hypertension, where you can see that the pulmonary artery diastolic pressure and the left ventricular end diastolic pressure are not much different. On the other hand, this is reactive pulmonary hypertension, where you can clearly see this is the pulmonary artery pressure and this is the left ventricular end diastolic pressure. So-called active, reactive, mixed out of proportion pulmonary hypertension has, as we said, certain problems with definition. The capillary wedge pressure versus the left ventricular end diastolic pressure, heart failure versus combined etiology or pulmonary hypertension due to other lung disease, particularly with a preserved ejection fraction, and acute versus delayed reversibility, because many patients who prove to be poorly responsive to vasodilator therapy on an acute basis will later on respond. And so how are we going to classify late responders or late reversibility patients? This is a summary of the definition by hemodynamics. As you can see here, this is the group we are talking about, group 2, pulmonary hypertension of the reactive variety, where the transpulmonic gradient is high and the pulmonary vascular resistance is high. The prevalence among heart failure patients, this is interesting. If you look at the studies which were done by echocardiography, they tend to demonstrate higher prevalence figures. I believe echocardiography exaggerates the prevalence estimation of these patients. If you look, on the other hand, on trials that use invasive measures, they tend to produce low figures. And when we go through the pathophysiology and pathology, we can clearly define, let alone the 4-stage classification, we can clearly define an early reversible and a late largely irreversible situation. In the early phase, where just the problem is the hydrostatic pressure, the changes are largely reversible, whereas in a later stage where the reaction starts to take place in the interstitial space with activation of cytokines, matrix metalloproteinases, recruitment of leukocytes, and subsequent medial hypertrophy, disruption of the internal elastic lamina, that the changes start to become more and more irreversible. The pulmonary vascular endothelium plays a central role in this situation. Pulmonary vascular endothelium is a secretor of three important molecules: nitric oxide, endothelin-1, and prostacyclin. Whereas nitric oxide and prostacyclin are the good guys, which are largely secreted by healthy endothelium, the inability of the endothelium to check the activation of endothelin-1, which occurs with endothelial dysfunction, is an important pathological hallmark of this disease. You can notice that nitric oxide activates cyclic GMP, and cyclic GMP produces vasorelaxation. And two levels of intervention are potentially available here: the phosphodiesterase 5 inhibitors and the activators, soluble activators of soluble cyclic GMP, Riosig-Watt is a currently available drug. We need to just notice that cyclic guanosine monophosphate is not merely a vasodilator. It also, in addition to the vascular tone, it promotes proliferation and fibrosis, and this is where it all starts to become irreversible. Something is going wrong here. I am not having the slide moving, please. Oh yeah, thank you. Now, the central role of endothelin is demonstrated in these two charts. This one here, in the upper one, shows the relation between the mean pulmonary artery pressure and the endothelin level, whereas this one demonstrates the response of the pulmonary artery mean pressure and the pulmonary vascular gradient to the administration of small dose white column and large dose endothelin receptor antagonist. Pathological changes start by congestion, followed by fibrosis, occlusion of the lumens of the septal veins, and later on you can see obstructive fibrous intimal thickening. Later on you can see focal thickening of the alveolar septa, and in the end stage you can see not only nodular capillary proliferation known as angiomatoids, but also hemosiderin-laden alveolar macrophages, which generally represent irreversibility. So, in summary, the pathophysiology passes through three stages. Passive increase in the mean pulmonary artery pressure brought about by factors like diastolic dysfunction, systolic dysfunction, loss of left atrial compliance, and exercise-induced mitral regurg, which is not often seen in the resting echocardiogram, with an added component of endothelial dysfunction, vasoconstriction, and finally, a stage of significant pulmonary vascular disease, right ventricular hypertrophy, which is a major omen in the terminal spiral. This is why the pulmonary artery diastolic pressure is a better predictor than the mean pulmonary wedge pressure, because it is not modulated, it's not modulated by the right ventricular stroke volume. This is the mean pulmonary artery pressure with different right ventricular stroke volumes. This is the mean pulmonary artery systolic pressure with different right ventricular stroke volumes, whereas this is the diastolic pulmonary artery pressure. Diastolic pulmonary artery pressure is not modulated by right ventricular stroke volumes, and that's why it's the ideal comparator. Yet, we need to use the mean pulmonary artery pressure because we need it for calculation of the pulmonary vascular resistance. Clinical features, I have nothing new to tell you, but a very important thing to remember here is that right ventricular hypertrophy in the electrocardiogram is not always clearly demonstrated in the presence of concomitant left ventricular hypertrophy. Remember that the criteria of ventricular hypertrophy are established in isolation. We don't have criteria for biventricular hypertrophy. And in the echocardiogram, as my esteemed previous speaker said, it's of utmost importance to scrutinize the right ventricle. Cardiac catheterization is the ultimate and the essential step in the evaluation of these patients. And when we see patients who have a pulmonary capillary wedge pressure that is high and the transpulmonary gradient is also high, these patients have to be subjected to a vasodilator test and managed according to the response. As I said, what we are not sure of is what to do with the late responders. We know how to manage the early responders. The right ventricle is a very peculiar chamber, not only because of its peculiar anatomy and method of contractility, but because elevated overload leads to reduced output, and that facilitates edema accumulation. But in addition, a vicious circle of pulmonary vascular resistance increases, interstitial fluid accumulation occurs, partly because of right-sided failure, which in turn further increases resistance. And right ventricular failure increases the accumulation of fluid in addition to decreasing the filtration pressure by raising the pressure in the inferior vena cava, and that leads to further fluid retention. But most ominously, look at this curve. This is the response of the stroke volume of the right ventricle as compared to the left ventricle in response to increasing afterload, whereas the left ventricle can resist increasing afterload for quite some time, the right ventricle fails very quickly in response to increasing afterload. The impact on survival, universal. Whether you look at the general population, A, those without cardiopulmonary disease, HFpEF, HFrEF, always high pulmonary artery pressure ushers bad prognosis. Drug therapy, and when you see a myriad of drugs like this, you conclude that none of them is ideal or close to ideal. This is pulmonary hypertension with preserved ejection fraction, the use of phosphodiesterase 5 inhibitors. And it shows an improvement of the pulmonary vascular resistance after 6 months that is maintained for 1 year. These are the completed randomized controlled trials using prostanoids and endothelium receptor antagonists. And what I'm going to draw your attention is the results, which I produce magnified here. You can see early termination trend to increase the survival, but no actual benefit. There is decreased survival in the treated group actually. Early termination drug-induced fluid retention, no effect. Increased cardiac output, no change in pulmonary artery wedge pressure, no effect. So generally, the results are not up to our expectation. Riociguat, the soluble cyclic guanosine monophosphate activator, is promising. It improves the exercise tolerance, and there are 2 of 4 ongoing trials that utilize riociguat. The results of these trials are awaited, but currently we don't have solid evidence on morbidity, mortality, long-term prognosis yet, only improved exercise tolerance, just like the previous drugs. So in summary, passive pulmonary hypertension improves on anti-failure treatment, whereas reactive pulmonary hypertension, which is present, by the way, in about half the patients with heart failure, does not. Diagnosis requires accurate hemodynamics and vasodilator challenge. Difficulties do exist, particularly in heart failure with preserved ejection fraction and when there is a concomitant cause for pulmonary hypertension, just like the previous instructive case we just saw. Pulmonary hypertension has a negative effect on survival in all situations, whether you're talking about left-sided failure, right-sided failure, ventricular assist device, eligibility for transplantation, everything. It always ushers bad prognosis. Available treatment may improve effort tolerance, have a limited effect on prognosis, and we are waiting for randomized controlled trials. Thank you very much.